Yeah, we wanted to go Monday morning, but Monday morning is Piers Cuppa, and I don't want to like step on any toes. Like that's kind of like their time now, so it's kind of like
Yeah, unless we do like a weekend, but then weekend, I don't know. I feel like people want to keep their weekends.
also didn't people say that they wanted head start? So I was like thought that they wanted the start of the week.
Yeah.
Ugh.
Maybe we should rethink our time again.
It's just because we're in like isolation, like that's why it's so like
Gauge anything. That's right.
I really suck at it. Don't worry, we all do.
Oh, Kanoot is so cute. Oh, I'm gonna steal that.
Monday
That's for
evening
next
was
time.
pretty good.
Kanoot.
We didn't do Monday evening because we thought everyone would be like last
Preparing
minute
for Tuesday, yeah.
That's why we didn't do it.
Honestly, we probably could have done Monday.
Yeah. And we also didn't realize that people's
Oi, get the PS Papa out of here.
Jokes, you can use all PSPs. Monday, Sunday, and
Monday evening.
Saturdays.
Maybe we should do Monday evening then.
Yeah, just David can never make Monday evenings.
Yeah.
Are you tutoring?
No, I've got Bible study on Monday evenings.
Okay.
Maybe we should just do a poll and just whichever day gets the most votes, just do that day.
2, 3, 4, 5. Yeah, that's everyone. Let's go. Oh, that's so sad. That's okay.
People better come this Saturday though, otherwise it's just going to be like there's no point in us doing a session on Saturday then.
Yeah, because like we know we have an Anki. We know that the Anki session got scheduled for Friday, which is the day before ours. But
did you need to explain that? That was like everyone like got it except one person.
I don't. Yeah,
I really suck at med doesn't really suck at med. Hey.
Nah, I think since it's so few people, you can just chuck questions in the chat, I reckon.
Yeah.
Or you can just unmute yourself. That's cool as well.
Not scary.
Yeah. Wait, so did anyone have the history today? Oh, got to explain this one.
David, do you want to do this one? I just took this from your slide.
Yeah, so like it helps with like everything else, right? Because like we're thinking about it like as a sugar coat, and what does a sugar coat do? Well, like sugar coat, it's like really strong, right? So it protects us from being like even. So that's resisting phagocytosis. So it does do that desiccation. I think there's like double S there, but essentially just means it doesn't dry up.
Did I spell that wrong?
Maybe.
Yeah, I did. Sorry.
Molecular mimicry is like they use glycocalyx to kind of be like, hey, I'm a protein as well, don't eat me. Or like, I'm a carbohydrate as well, don't eat me. Whereas like intracellular communication is more so like your pili, your Fimbriae for adhesions, as well as like your sex pili. Those are kind of the reproductive kind of asexual reproductions for bacteria. So, yeah.
Sorry guys, I really butchered that spelling. I don't know what happened there, but I got it really wrong.
Oh, good.
Okay, let's ignore that. Cute. That's just a fact. Kind of self-explanatory though, like if it's surgical equipment, it's going to be piercing skin. If it's going to get into anything, if it's going to be piercing skin, you want it to be sterilized. These questions are pretty like, I was like really dead when I was writing these questions this morning.
Dead questions means nicer questions, I think. Nice.
Yep, high level disinfection. This is just a fact, like anesthesia breathing equipment, so it's like semi-critical, so that would be high level disinfection.
Because you're like sticking it into them, so you don't want it.
Yeah.
Yeah.
So it's technically not like piercing skin. Like it shouldn't. Because if it does, then that's a whole other problem that you're going to have. But yeah. Kanoot.
I'm going to steal Kanoot. I'm going to use that in the
It's
next
cute.
post.
Yeah.
Love that. Who's Kanoot? I'll give you credit.
Okay, so I had fun with this question, except it was really hard to find other. So heat, radiation, filtration, and chemical are your 4 types of sterilization methods. The rest, so heat, radiation, UV is a type of radiation sterilization, and chlorine is a chemical disinfectant. Iodine as well is chemical disinfectant. Ionization and UV are both like the radiation sterilization, and chlorhexidine is a chemical disinfectant.
There's obviously going to be more to diagnosing.
Yeah,
this, but based off that one rule they gave,
yeah,
fever in a return traveler is
fever in a return traveler is always
is malaria.
So you're telling me med isn't just like a flowchart?
I mean, it basically is a flowchart.
Yeah, it's like you go from one to the next to the next to the next, and
It's just
like
a flowchart with like a few circles.
You just cut it down further and further until you get like a few left.
And you take a random stab in the dark.
Giardia, that's people with Giardia present with greasy. That's like a buzzword. Greasy,
foul-smelling stools that float because they're full of fat. Normally from a return traveller who's probably had some contaminated water. When they've gone overseas, that's like buzzwords for Giardia in first year.
Basically, you'll never diagnose purely based on this. Like, there's going to be so many other things that will affect your diagnosis. But
you would probably just culture them and then just like look at the culture.
Yeah, and then you'll realize.
Yeah.
Did we ever get questions like this in the exam? Like, I can't remember.
There were like no questions on parasites, I'm pretty sure.
Yeah. But I was really stuck for questions, so I just...
Yeah, I really hated microbiome as well. Like David's like the person who loves microbiome the most. I've never seen someone love it more.
Microbiome is really cool though. It's just a very annoying subject to like learn.
Yeah. Okay, this question here.
So the threadworm is Jatine, do you want to explain this? I made this question for you because you liked the text.
That one? Yeah, so that's the one where the parasite, the female parasite, essentially crawls out of your butt, essentially, at night and lays her eggs around your butt. That's why you normally get itching at midnight. And one of the easy ways to diagnose it is to actually get a piece of tape, like stick the tape on the butt, and then look at the tape under a microscope and you'll actually see the eggs. Yeah.
Yeah, that's just... There we go. Microbiome. I swear we never really got these questions. Like,
yeah.
Most of your parasites, though, you basically treat with like one of these things. Yeah, like you go over these parasites and these nematodes again in second year. Like, I don't think I memorized any of these parasites last year.
I barely remember having this lecture.
But yeah, like, so I was doing a table like the other week for our parasites, and like all of them, you basically treat with a metronidazole, which is something that stops your DNA synthesis. Doxy, you mostly use for malaria in your exams.
But significant side effects.
Yeah, significant side effects. Like, you don't want to use it in young children or pregnant women because it disrupts your bone formation and you end up with bad results. Tinidazole.
That's another one, but that one's for, I think it was for Giardia. It was like tinidazole. however you say that, and
metronidazole. Yeah. Metronidazole is the main one.
Yeah. I just got this from your slides, Peter.
Yeah, hang on. Okay, so fibrinolysis is not inhibited by, so you got to pay attention to the not. So your red option, plasminogen activator inhibitor, I think that one's a pretty obvious, like it can't be correct because your plasminogen activator is going to dissolve your clots. So if you have an inhibitor of that, it's going to stop dissolving it. Alpha-2 macroglobulin, I honestly do not remember what that is.
It was just in the list. You listed out a couple, and like that was in the list.
Yes, I did. Yeah, it's simply just a list. Alpha-1 doesn't actually refer to anything, I think.
Yeah, it's
Alpha-1,
alpha-2.
if you see Alpha-1 just by itself, it's probably referring to a receptor. But yeah. You can also see blue if it has antiplasmin, plasminogen. So antiplasmin, plasmin is going to be somehow involved in your fibrinolysis. So if you go against plasmin, then you're going to inhibit fibrinolysis.
Cute. I like ran out of options. I was like, whatever.
Oh wow, you really did. That's okay. Nice, good. So the extrinsic pathway, I like to always think of it extrinsic. You're going to get damage from the outside. If you get like, I don't know, punched or something, that's going to hurt your tissue rather than your blood vessels. Whereas an intrinsic like kind of damage is going to hurt your blood vessels because your blood vessels are on the inside. So extrinsic will be activated by tissue damage and intrinsic by blood vessel damage. Any of the above causes would be the answer if it was like the common pathway for the coagulation cascade is activated when there is either blood vessel or tissue damage, because either way you're going to go through the common pathway.
I was gonna do the like select all that apply, but you had to have a pro account to do that kind of question, so I was really sad. So I had to change to it to make it accept.
Yeah. Okay. So I think for this question, the best way to think about it is looking at all the options and thinking about what's a condition and what's which one of these are a condition, which is deep vein thrombosis, and which ones are kind of things that go wrong or like are part of a condition. So endothelial injuries, that's not a condition in particular. It's going to be referring to like any injury of the blood vessels. Same with abnormal coagulation and abnormal blood flow. So all the red, blue, and green options are going to increase the likelihood of thrombosis, and deep vein thrombosis is an example of like when you get clotting when you don't need it. So therefore, Virchow's triad does not include deep vein thrombosis.
Oh wait, no, this wasn't the question. There was another question where it was like, you can tell that I literally could not think of any more answers.
Yep, so cell injury, think about cell injury like you've fallen over. So when you fall over, you're not going to get an immediate infection, right? The first things you're going to get are, it's going to turn red, it might swell a bit, you're going to be in pain, you probably won't be able to walk on your leg as well. So therefore, tumor, which should be spelled, like all of these should be without a U.
Oh, really?
Yeah, it's not tumor, it's tumor, like a Latin T-U-M-O-R. So that's swelling. Yeah, and same with rubor. Rubor should be just B-O-U, sorry. Rubor should be R-U-B-O-R, which is redness, and functio lacer is loss of function. So cellular injury can still occur without infection. That's like what happens in surgery. Like you're still injuring cells when you're cutting the person open, and hopefully it doesn't result in infection. Yep, good. So it's all of the above. Atrophy being you kind of lose out of your cells. Metaplasia being the cells change, and both of those can occur. Both of those are options when you get injured. So therefore, it's all of the above.
I was out of options.
Nice. Yeah, so necrosis is your bad one. Apoptosis is your good one. So apoptosis is controlled cell death, whereas necrosis is kind of, if you burn yourself, for example, that'll result in necrosis. If you let an infection get too large, or too widespread, you're going to get necrosis. So necrosis happens accidentally, and it's premature, and it's uncontrolled. With these questions, I would just go about them like just in a way that you would think if you were Craig. So if you were Craig, you probably want to prove a point. You want to prove a point about how lazy Australia is, right? So therefore, it's not going to be 20 or 35%. He's going to like try to shock you with some facts. So therefore,
but yeah, it's usually not too shocking though. So it's not like 90% or like 100% of people. Like, yeah, it's not like that. Yeah, it wouldn't be too major, but it'd be like enough for him to go, wow, see this statistic? Like, whoa. Like, yeah.
Yeah, you guys are so sedentary. So therefore it's 70. So you kind of want to go on the higher side, but not the highest.
Like, yeah.
This is such an attack on all of us.
Yeah, no, 30 to 45 minutes a day. I'm like, in ISO, cute.
So 30 to 45 minutes of moderate exercise every day is recommended. 1 hour to 1.5 is 1 hour and above is a bit excessive, I would say. Yeah, that might be say if you're just walking like to and from work or like
around
to and from the car, around the house. Not really exercise. But yeah, if we're considering moderate exercise, then it's about 30 to 45 minutes.
Oh, this one, I think, this one might be hard. It's just a fact.
Yeah, it's
Pretty
okay.
sure if you reach like VO2 max of like 80 and 90, even like you're pretty bad. Like
Yeah.
it's pretty intense if you are reaching that.
You also want to think about like if you're exercising, this exercise is going to refer to like your moderate exercise and not you like straight out sprinting and like doing all sorts of crazy things in a really short amount of time. So you don't want to go for the extreme options. You want to go for around the middle, 60 to 70%. Better be. Okay, that's right.
It's not coming. It's okay. It's okay. People have things on. It's okay.
Work-life balance. Kanoot. Very
Kanoot.
nice.
You want to use that?
Double smiley face. And microbiome, right?
Yeah. Microbiome with a sad face.
How does that make you feel, David?
Sad.
Sad. Okie dokes. Does anyone have any questions about this stuff?
Okay, cute. Do you guys want to?
Okay, let's get started then.
We'll get started.
I reckon this week will be a bit quicker, right?
This week doesn't have too much, I don't think.
Yeah. Okay.
Except for David's psych, maybe.
Yeah.
Psych is.
Yeah, psych is psych. Jatine, do you want to get started on HKS?
Yep, okay.
Guys, HKX is actually really important this week.
Yeah.
Let's just give you a heads up.
Psych is
Okay.
not.
Psych is psych.
Okay, so
see
this
how
week
that's like.
in HKS, you guys will be covering refugee and asylum seeker health. This is actually probably one of the most high yield HKS areas of study, so I would pay attention. Of course, once again, not everything will be included in my slides. This is just a quick summary of all the important points. So first of all, you've got to know a few definitions. You actually do need to know the definitions for this. So first of all is, what is a refugee? So refugee is defined as a person who is outside their own country and is unable to unwillingly return due to a well-founded fear of being persecuted because of their race, religion, membership of a particular social group, or political opinion. An asylum seeker, so this is someone who is seeking international protection to become a refugee, but their refugee status has not yet been confirmed. So normally when you are a refugee, you do get access to certain international protection. However, if you're still an asylum seeker, because your refugee status has not been attained yet, you're not qualified for those protections. Someone who is internally displaced, so that's people are still under the control of their own government and do not fit under the definition of an asylum seeker. So they're unable to gain refugee status. So they actually can't go to the next step of actually trying to seek refugee status at all. And a climate refugee, so this, I don't know about now, but last year when we were still learning this, a climate refugee, they were still not protected under the UN Refugee Convention. I believe they still aren't. And so they cannot receive any protections, once again, as what a person who is qualified as a refugee would receive. So we essentially, Australia has two refugee and humanitarian programs. So one is offshore and one is onshore. So when Matthew goes through this, essentially what he wants to get you guys to understand is offshore is typically considered the good one, and onshore is more controversial. And a lot of people think that it's a really bad program. So we'll go through the good one, which is the offshore first. So this provides resettlement in Australia for refugees and humanitarian entrants from overseas. So what happens is Australia essentially listens to the UNHCR, which I believe stands for the United Nations High Commission for Refugees. So Australia listens to the United Nations, who tells us which people are eligible or should come to Australia as a refugee. So these people are officially classified as refugees and therefore get all the international protections. After Australia listens to the UN, we essentially provide support for these refugees to come to Australia. And once they do come to our country, our nation also provides support, including access to school, free accommodation for when they first come, as well as pay for their trip to actually get from their original country to Australia. So as you can see, the offshore program is pretty good. The onshore program, on the other hand, is not as nice. So it offers a degree of protection to people who arrive in Australia, but essentially they're never allowed to live in Australia. So for example, if they arrive by boat, which is unauthorized, they essentially will be carrying no visa. They're not eligible to live in Australia forever. But because they're still under, I guess, the certain protection that a refugee has, Australia, what we're currently doing is we're sending them to an offshore detention. And when we send them there, it's really just ends up becoming like an indefinite mandatory detention for them. So they can't really leave, but they can't really come to Australia and live the life that they've always wanted to. Once again, if they arrive by plane, normally if they arrive by plane, they're authorized. So these people will seek asylum after already having a tourist or a student visa. One thing you guys also need to consider is the impacts that refugees and asylum seekers essentially have to go through, and these can be divided mainly into two categories. So one is pre-arrival, so what they go through before they come to Australia, and one is post-arrival, so the things that they have to experience when they actually get to Australia. So pre-arrival is essentially everything that's happening in their original country and through their journey of them making it from their country to Australia. So this could be things like the standard of the health system from where they came from, which could be very poor. It could be experiences of the individuals. They could have gone through conflict. They might have gone through trauma, especially if they've had to go through a really long, treacherous journey to actually get to Australia. And throughout that journey, it's quite obvious that they would not have adequate access to healthcare. So if they do get sick midway through coming to Australia, then they can't really seek professional Medicare help anywhere. Post-arrival, so once they arrive in Australia, normally they will experience things such as language barriers. They might also experience prejudice and cultural insensitivity from people in Australia. And so therefore, because of these problems, such as language barriers, they would have difficulty accessing healthcare within Australia. There's problems with health screening. They might not be financially stable once they arrive because they have a difficult time finding a job, etc., etc. So there's a long list, and this is definitely not a complete list, just something to give you a general idea of the impacts on refugees and asylum seekers. So what can we do to help? So my three essentially says there's 3 simple steps that we can do to make a difference for these people. And this is ask, screen, and kindness. So when we talk about ask, this means we actually ask them questions, of course. So that could include things like their country of origin and ethnicity, so that we can be culturally sensitive. We can ask them about their arrival details, where they came from. So therefore, that could help us in knowing what conditions that we might have to screen them for when they come into a hospital. We might also want to ask about what their native language is, so that if an interpreter is required, then we can get that to them as well. So screen is essentially where we screen them for any health diseases to provide essentially a comprehensive health assessment. And this goes for both their physical health as well as their mental health. So common diseases that you would screen for include something that I probably cannot pronounce, schistosomiasis. So this is a parasitic worm that can infect humans by essentially crawling their way through the skin of your feet. And normally they do so when people go into water sources to either drink water or fetch water. Another one is strongyloids. Once again, it's another parasite and it can cause chronic diarrhea and abdominal pain. Another common one to screen for in refugees is vitamin D deficiency. Part of the screening process, you should also ascertain what their immunization status is and whether or not they need to get any booster shots or any new shots. And the last one is kindness, which is pretty straightforward. So this just means we do have to be aware and sensitive of the things that they might have gone through before coming to Australia, as well as the things that they are going through currently in Australia. These especially includes things like possible past trauma. So for example, when you know that a patient has come in and they are a refugee, maybe you could allocate more time for the appointment so that you can take a more full medical history, screen for certain diseases, and it also gives you time to ask them where they're originally from, as well as get an interpreter if needed. And overall, it helps to coordinate and integrate appropriate care for them. Okay, great. So I've quickly summarized one very important lecture into just a few slides, but once again, very important that I would recommend you actually watch this lecture because it is important. And I'm pretty sure you will also get active learning where you'll go through what a sample question for your exam might look like. Normally, if you actually had exams that weren't online, HKS would be short answer. And so a typical question might be a single mother with her 2 children has just arrived in Australia and they're refugees. Discuss discuss how their refugee status has an impact on their health and what you could do as a health professional. Yeah. So then you would go through all the impacts that they had pre-arrival, post-arrival, and then go through what you would do in terms of ask, screen, and kindness. Cool.
All right, pharmacokinetics. Audrey?
Yeah, I can take over. So it's supposed to be Zoe, but she couldn't make it today, so I'll just go through with you all. Right. So pharmacokinetics is not too much. Hold on. Yeah, so pharmacokinetics, it's basically looking at what the body does to the drug. So there are a few phases of drug action. So when you consume a drug, or any kind of medication, the drug has to be released from its package form. And the pharmacokinetic phase is when the drug is actually absorbed and distributed throughout your bloodstream and to different parts of your body, then metabolized in certain areas in your body, and then excreted out. And that's what, so in a sense, it's basically what the body does to the drug, right? And in comparison, like pharmacodynamics is what the drug does to the body. So these are 2 different concepts that you really need to know. And pharmacodynamics is basically the drug binding to a target site and stimulating an effect. So why do you care about pharmacokinetics? It's because there's basically quite a few reasons. You need to know the dosages, as well as the best route of administration, the starting dose, and how frequent one should actually take this drug. And so that you can ensure there's not too high of a level of a drug in your bloodstream, which can be toxic. And yeah, so there's a few other reasons, like you would also want to prevent dose-dependent adverse effects of drugs. So that just refers to when you take drugs depending on their dose rather than time. So it's more of the half-life, if I'm not wrong. Yeah. And management of drug overdose. So again, it's just basically you just want to have too high level of a drug in your bloodstream. And yeah, so the last statement is you want to ensure it's not too high, but also high enough such that it's at the therapeutic range. Okay, so like I was saying, you need to consider many different routes of administration. So you're very common, probably pretty common with oral and injections. So that's something that you might have experienced throughout your life. But there's also many other ways. So there's sublingual, and rectal, intravaginal, intraurethral. There's lots of methods, but you don't really need to know all of these by heart. You just need to know that there are many other methods than the typical oral and injections. Yeah. So I'll just go through. So sublingual just means under your tongue. Rectal, it's pretty obvious. Intravaginal, intraurethral, inhalational. So you probably get exposed to these later on in the year, especially when you do cardiovascular system, as well as next year when you start doing respiration as well. So the preferred route of administration usually is oral. So that's why many of you would probably know this. But why would we even do other methods if you could just do oral, right? Actually, sometimes you can't take the drug through the oral method because it could be unstable. So like for example, insulin is broken down if it's taken by mouth. And the other reasons, perhaps like if the patient is unconscious, if absorption triggers, like if the absorption is actually affected because of the disease state. So if you're actually ill and you take take the pill, you might end up just vomiting it out. Or also if you want to have a local effect, you don't want to spread the whole effects of the drug throughout the body, you wouldn't usually take it orally then. So movement through membranes. So important thing to know is that the drug needs to pass through the cell, right? So the membrane is actually made up of a lipid bilayer. So in order for the drug to pass through, usually it would have to be you'd have to pass through passive diffusion, which means that it's lipid soluble. Or if it has an aqueous channel, it can pass through that as well. Sometimes you would also need a carrier mediated transport as well. And so the main thing is that drugs can diffuse much more easily if they are lipid soluble compared to if they are if they have a low lipid solubility. So, many drugs can exist in either weak acids or bases, and it depends on the pH of the environment. So, you have different, for example, if you ingest the pill, you'll be exposed to different pH conditions when you as it passes down the digestive system. And so some drugs which are weak acids, so for example, like let's say it enters your stomach, right? So it's being exposed to a strong acidic condition, right? So if your pill is already if your drug is already a weak acid, it becomes ionized. So if your drug is a base, it becomes ionized in that acidic condition, right? So when it becomes ionized, it basically means it can becomes charged, and when it becomes charged, it has a low lipid solubility, so it doesn't pass into your cells. So instead, when it passes down through your small intestine, which has a base environment, it'll have a higher lipid solubility and then pass through into your cells. And it's the opposite for acidic drugs. So the main thing you need to know is that ionized are charged, so it means it has a low lipid solubility, and unionized is uncharged or could be neutral, and it just has a good lipid solubility. And this whole thing depends on the pKa value of the drug. So the pKa value is basically the pH where 50% of the drug is ionized and 50% of the drug is unionized. Yeah. So this is important because your body has this system of ion trapping. So like I was saying, molecules are less able to pass through if they are charged, and the because they have a lower lipid solubility. So if you have a weak acid as a drug, it tends to accumulate in urine because urine has a very high pH, and that's how your body can get rid of it. And similarly, weak bases accumulate in gastric juices, and they just aren't absorbed into your bloodstream at that point. And this is how your body helps to regulate the amount of drug that's actually being absorbed into your bloodstream. Okay, and that's basically the main concepts you need to know for pharmacokinetics. And yeah, the main thing you need to remember is that bases are ionized in acidic conditions and acids ionized in basic conditions. And that affects their solubility and that affects their absorption. And yeah, that's basically it for pharmacokinetics.
Yeah, sweet. So David, do you want to go now?
Yeah.
So David's going to bring us psych, and then we'll go through the tissue healing and stuff as well.
How many on here? It's 13 on me. Good to see everyone. Good to see you. Peter, could you share, please?
Oh, wow.
Or can someone share? Like,
yeah, just give me a sec. Give me a sec to prepare. Hang on. Psych. Right. Has anyone found psych particularly difficult so far, or is it like pretty okay? What's the vibe everyone's getting from psych? Screen one. Okay. There you go.
All right, easy. I'll try and blitz through this so we can all get some sleep. All right, so stress, right? Like when we think of stress, Glenn Melbourne, yeah, it literally today, if you've done 3 or 4 psych, just like kind of switch off, but not really, because I've got good stuff coming. Okay, so psych, there's 3 main sections. Essentially, just think of it like external stimulus, like, you know, like your mum comes at you with like a slip up because you only got a B+ on your English exam or something. So that's like external stress, and then you have like transactional between external events and like how you actually perceive it, and then internal physiological reaction. So that's more of kind of like how you actually respond to it and the processes that occur physiologically to actually help you adapt to that stress. Yes. Next, thanks. Yeah, so autonomic nervous system, you kind of need to know a bit of the basics ideas of the nervous system to actually understand how psych actually plays into the more medical part of our mental health. Well, autonomic nervous system, I'm sure you guys have you guys covered this in like other lectures? You have, right? Yep. So I'm just gonna skip this then because like we've already covered this. We'll skip that and we'll skip that. All right, so impacts of stress. So what impacts of stress are there? There's cognitive effects, there's physical effects, there's emotional effects, behavioral effects, organizational effects. So the cognitive effects is like you're trying your best to like answer that multiple choice question, but literally every single response looks the same, and you're just unable to focus. Emotional effects is like you're feeling really bad in the dumpster, you're like really angry at everyone. Even when people do something nice for you, you don't really, you find it difficult to kind of empathize with others. Physical effects is more so like the actual physiological responses to it, right? Like increased heart rate, increased blood pressure. Some people, when they stress, like the eyelids become like monolids or like becomes 2 lids. Is it duolids? I don't know if that's a term. And also your immune system becomes impaired as well. Organizational effects is like, let's say you don't turn up to a lecture or things like that. So it's more so like your lifestyle and your behavior. Whenever we think of psych, like everyone who's done 3-4 always do like ABCs, right? So A is affective, so that's your emotions. B is your behavior, so like what you're doing, like, and things like that. And cognition is more so like the way that you're thinking. So use all of these as a way to kind of frame the idea of how we think about different aspects of psychiatry. All right, so this is just like an example of why stress actually leads to a negative cycle. So let's say your name is Ben, right? Or like you're a first-year medical student And uni just cancelled your Sem 1 exams, like, oh, that's really good. But then suddenly it's end of the year and you panic. So you haven't studied much at all, like you stress, immune system gets worse. So that's your physical, and you get chronic stress, right? Because of chronic stress, increased cortisol levels, and because of that, therefore, you also are more likely to get a worse immune system. So that's your cold and stuff. And then you get to, like, later on, like, because of the cold, you're going to revision lectures. No revision lectures means you can't concentrate, like, properly, and you feel like you're studying less. And then you just potato at home and just watch Netflix all day. So this example is kind of oddly specific. So let's just say I don't know anyone personally who's done that, other than that's it. All right, yeah, let's move on. Yeah. So types of stress, just think about it as like acute stress. Well, like it's a big thing, right? Like it's a big exam coming up, your house burnt down and you broke up with your significant other. In chronic stress, it's like university stress, so like you're studying all day and you're like, oh my God, I don't have a life. And then, or like you lost all your possessions from your house burning down and now you're homeless. So that's chronic stress, because homeless is a longer period thing. Or like you feel depressed that no one will still ever love you again after your significant other broke up with you, but don't worry, we kind of still love you. Yeah. The point is, right? The point is that acute stress can often lead to chronic stress. So all of these things, they're never like in isolation. Like you can't, and we have to, as clinicians, we often have to like create these sort of interventions to prevent acute stress from leading on to chronic stress. Welcome, Enoch. Okay, so the Yerkes-Dodson curve. So what is this? Well, let's just think of it as like, so the more right on the x-axis you go, is like the more aroused you are, the more like you can be like agitated, or the more aware that you are. So if you're super aroused, like to the point where it's actually not effective, it leads you to like literally do nothing, and you're like stressed beyond your mind, and you actually have a breakdown. So #relate. So in terms of arousal, if it's actually like at peak, you do really best in the exam. It's like, I know this, I'm going to get that bread. Like I'm totally in the flow state. Like I'm doing so well. So that's exactly what we want to be. Like not too stressed. And that's actually where we perform our best. But then like, if you think about it, like I worked in Woolies like in year 10, it was literally stacking shelves, and your arousal is like literally zero. And then you just do nothing. And then you're just like stacking away. Like it's very, yeah, like this is just my life today through this psych thing. So yes. Chronic stress. Well, why is it actually stressful? Well, firstly, like demand, right? Like it's demanding. If something is stressful, it's often demanding a lot. And chronic stress is demanding a lot of a long period of time. Like if I, like, you know, you're telling me that I have to memorize all of Krebs cycle, false. The true Krebs cycle is learning it every time you've forgotten it. So if we have to learn the entire biochem pathway, like literally every single semester or something like that, then of course you're going to feel overwhelmed, because that's so much demand. And luckily Nirma, bless her, that she tells us some things we don't need to memorize. So for controllability, right? Like we need to think about if we have no input to the task or no voice, then we will often feel really overwhelmed that we just kind of can't do anything to change the situation. So, and predictability, like if faculty didn't give us an outline of semester, we'll literally be like feeling our way through the dark, and that'll be really stressful and scary. Ambiguity, what do we think of ambiguity? Well, ambiguity is like nothing's really clear. I'm sure like some of you have seen the love letters about a certain course, how everyone's like stressed out because everything's ambiguous. So we don't want that. We want clear communication, and that will lead to better outcomes for everyone. All right, so Lazarus focuses on the transactional model of stress. Just shout out to all the female psychiatrists out there, as this is like one of the first moments where I kind of actually saw female researchers in this world, so good on them. Okay, so step one, so primary appraisal, like, is this even a problem? Like, if it is not a problem, then you won't move to the next step, right? Like, let's say the example of exam, or like, this is a problem because I haven't done bio and I need to do a lot of revision for this exam. So immediately I say, this is a problem. Okay, and then I get to secondary appraisal. So what's secondary appraisal? Well, secondary appraisal is actually seeing if this problem is stressful or not. Like, it may be a problem, but it might not be stressful. So then that issue instead. But like in secondary appraisal, if I'm thinking like, all right, my coping strategies actually don't match up well enough, so then I'm going to feel overwhelmed. And that's why you can feel a sense of overwhelmment, if that's a word. That's not a word. Stress. So what's stress? Well, that's actually the physical kind of reaction towards like, oh my God, I'm having a breakdown. I literally can't do this. And coping strategies is like using problem-based or emotional-based strategies to actually deal with this. Where appraisal being like your friend is like, dude, you're like straight up overreacting. Just calm down, take a breath, you can do it. And then you're like, okay, I actually can do this. And you appraise the situation so that you can better react to it all. Easy. Okay, so Lazarus and focusing on stress was actually their model of stress. So you was smart, you was kind, and you was important. Well, this is why reappraisal is really important, right? Like, allows us to rethink the current situation and get out of chronic stress as soon as possible. And if our situation, like, we need to think about how we perceive stress and whether this thing is actually stressful or not. And if it is, like, is there anything we can do about it? And if there isn't, what other strategies can we employ to help us deal with the stress? So coping strategies, we have the problem-based strategies with like focusing on the problem and dealing it with like heads on, so like actually dealing with the problem. So for example, let's say you feel like you can't find a job because John Doe comes to your clinic and says that he can't find a job because he has no skills. So a problem-based strategy could be like telling him to enroll in a TAFE course to upskill. So this is just like focusing on the actual issue. Whereas emotional-based support is like when you don't have anything that you can do specifically about the problem at hand. So you just focus on the way you feel and your overall kind of affective, so that's your emotional kind of well-being. All right, so a bit of a meme. So what is wrong with you? Nothing. I think it's just funny that right. So coping-based strategy, this is actually like the example on the right, like this is actually a case of problem-based coping that isn't very productive. A lot of times emotional coping and problem-based coping actually merges together. So emotion-based coping is more so focusing on how we can clear our thoughts and think clearer, whereas problem-based coping is like often dealing with the problem heads on. At the end of the day, just like make sure you take a deep breath and then consider the situation before actually making a decision. All right, so maladaptive coping strategies, just think of like anyone who's like overwhelmed to the point and using bad ways to actually adapt to the situation. So alcohol abuse, drinking of sorrow is a way, please don't do this. Violence or unleashing anger, like, recently with us in coronavirus isolation, there's been increasing rates of domestic violence. So all of these things are kind of maladaptive coping strategies that often come as a result of like unemployment and these other stresses. Drug abuse, similar to alcohol abuse. Denial of stress is like, nah, this isn't happening, like it's not real, bye. So that's like out of sight, out of mind. And all of these, we often call it avoidant coping strategies. They're synonymous between maladaptive too. And just note that emotional-based coping strategies is not necessarily avoidant. Like you're actually dealing with it, just not the actual issue, also focusing on your emotions regarding this issue. So what are some health impacts of stress? Well, you can think like heart attack, bowel disease, multiple sclerosis. This is kind of low yield, like this entire slide is like kind of low yield. I just kind of had it there to make it a little bit more comprehensive. And personality also affects the way that you kind of go about stress. Like if you think about it, like you're more of an anxious person in general, then like when you're stressed out, you're like, oh my God, like I literally can't do this. But in reality, that's just kind of a predisposition within your own personality. All right. Becoming ill. Okay, so what is attribution? Okay, so this lecture is actually pretty important. There's like 2 or 3 questions every year on SEM 1 paper about this lecture. So attribution is mostly talking about the start of how you perceive a symptom, let's say. So like, like suddenly, oh my God, I have a headache. And then you're like, WebMD, brain cancer, oh, I'm gonna die, right? Like it's like a very linear kind of way we think about things, but it's often not like that. So external attribution is like, Mom said that I got a cold because I spent too much time on my phone, or like I was stuck on the toilet for 2 hours because of that spicy dish, right? Like this isn't always true, and it is just an inference, and it has to be an external factor. This is the main thing about external attribution. So it's about like the external things, so like something beyond your like something outside of you as a person. Whereas like internal attribution is like, I'm munted from drinking too much alcohol at med camp, can't relate. And I have a headache because I slept for the last 48 hours. I haven't slept for the last 48 hours. Pretty sure if you sleep for the last 48 hours, you'll also wake up with a headache. So internal comes from within, like the responsibility is on you. All right, so same slide, but this time with emojis. Okay. So attribution, like stable versus unstable. So I'll never be able to have a good skincare routine. Like I haven't cleaned my skin much because I had no time at night. Like the first one is stable because it's like, I never, like it's permanent, right? Like look at the keywords, like I never. And then unstable is like, I haven't cleaned my skin because I have no time. It's conditional. Whereas we look at global, right? Like global versus specific. Global is kind of saying like, oh, like, you know, being paraplegic is impacting my entire life. Another keyword, entire. It's very definite as well, and it's wide ranging. Whereas specific is like being paraplegic means that there's some things I can't do, but there's a lot of things that I can do, and it doesn't prevent me from enjoying life. So it's more of an optimistic growth mindset. Whereas controllable and uncontrollable, just think of it as like, I can help my depression by taking antidepressants. So taking control, taking onus upon the situation. Whereas uncontrollable is like saying, I just know these tablets won't help my mood and it's all kind of pointless. A little bit more pessimistic. Yeah. So fundamental attribution error, like this is pretty important. Like listen, so make sure you kind of get this. Fundamental attribution error is like tendency of the observer to underestimate the impact of external factors and to overestimate the impact of internal factors. All right, so you just need an example for this and you'll 100% get it. Like everyone kind of has this bias, like whether we think about it or not, like sometimes it just happens. Like it's not something that it should just be something we are aware of. So for example, like you might see a homeless guy like near a supermarket, and then someone might say, oh, that guy isn't working hard at all, must be a drug addict. You kind of have that immediate like leap to the conclusion, but oftentimes that's a fundamental attribution error. Like we don't know that this is a situation, and we're just kind of saying like it is their fault that this current situation is, their current fate is because of their own result. But as we know, homelessness a lot of times happens as a result of domestic violence and as well as many other myriad of social issues. So another one being her schizophrenia is back because she never listens to what I tell her. Like it's all in her brain. If she got busy and kept a job, then she wouldn't have time to be depressed. Like all of these are fundamental attribution errors because as you're saying, like it's a patient's fault. It's a person who's suffering's fault. Whereas a lot of times we don't consider factors that are leading to this pain. And these are like examples I've actually heard people say, so it's quite common. Actor observer bias, so it's like kind of the opposite of it. So it's like more so you as being the patient or like you as being the individual that you like attribute all the kind of fault onto external factors. So you're saying like, oh, I'm feeling so depressed and overwhelmed at uni because, you know, the course demands so much of me. Or like you're saying like, it was, my relationship is broken because my significant other doesn't care about me enough or something like that. Like even though that might be true, but oftentimes we just have the bias to focus on external factors rather than our own internal kind of aspects as well. Cool, so actor observer bias, bit of a meme. So the key to remember here is that bias just means you favor one over the other. Like you don't consider any other factors. So while both factors may be true, you favor one to abnegate all of the responsibility of you. So if it's like me being like this dude here, and it's like my own despicable time management skills versus the university doesn't offer any support, like, you know, like one's on you and one's on uni, and it's easier to kind of get out of responsibility to not take control. Self-serving biases, literally, like I got 100% on that exam because I'm the biggest brain, or attributing like essentially just attributing all the successes to your own skills. Self-protecting bias is kind of saying you're just blaming someone else again to the situational circumstances. Self-handicapping is like you're literally saying like, oh my god, I'm gonna fail. I'm actually so dumb before the test has even happened. so that you can feel like, oh, if I do fail, then it's okay because I already said I was going to fail. And med students do this a lot. All right, signs versus symptoms. Signs is objective indication of disease, whereas symptoms are kind of interpretations by the patient and are slightly more subjective. So signs is like redness, erythema of your skin, or like acne, like showing inflammation. Whereas like symptoms is like, I have redness, therefore I have eczema, or like I feel nauseous in the morning when I eat, so therefore I'm pregnant. Like these are all symptoms, but they're not always signs. There's a bit of a blur line between the two. So there's sometimes a bit of overlap as well. And the symptoms are usually just based on these physiological changes. And we may experience like a bunch of symptoms every day. Like I literally have back pain right now. And then you're like, oh, like, do I have multiple sclerosis or like scoliosis of the back? Not necessarily. I've just been sitting for a long time today. So that could be another issue. Yeah. Next, yeah. So just some factors that kind of goes over the interpretation influences of symptoms like gender, cognitive age. So that's like your education background and stuff. Cultural influences, like we used to say like at dinner, like parents always say like, oh, if you have a thick neck, then you have a disease and you need to eat more seaweed. Like I don't know what correlation there is between that, but then like turns out being thick neck means you actually have goiter, and like that's actually bad and based on some like cultural things. So a lot of times like the way that we interpret culture has impacting our health literacy as well. Prior illness with prior experience with illness. So like if you've had cancer before and suddenly you feel really tired and you're losing weight, and then of course you'll be more scared that if the cancer is actually back. And the family history, I think you guys have talked about like familial adenomatous polyps. So that's like thinking, oh, like because my dad had FAP, then does that mean like I will also have colon cancer? Rip in chat, Ek Chong Te. Yeah. All right, good. So essentially that's stress done. Just look over actor observer bias and fundamental attribution error. That's probably like the highest yield for psych. Good night and thank you.
All right. See ya, David. Yeah, okay, cool. So I'll be presenting for the rest of it, and I think like we'll probably smash through this stuff. It's not too bad, I think. So first we'll start off with tissue healing and repair. So this is kind of continuation from last time, where we were talking about how different cells change and things like that. So this slide is like a bit of a recap from last time, just with a few different words. So resolution is like typically a good one. Small injuries, really short injuries, your cells basically come back to normal and everything's okay. But if there's a lot of damage, if it's chronic damage, if there's been a ton of inflammation, things aren't going so well, you're going to get scarring. So the main differences is resolution is fairly good, scarring is fairly bad. Yeah, and we'll be talking about like various types of wound healing. So depending on the wound you get, how it's kind of put back together, what's going to happen to it. But with all the wound healing, we're going to have 4 similar steps. We're going to have hemostasis, which is stopping the blood flow so you don't bleed out to death. So this includes our PPP, which is our primary platelet plug, and then the formation of a stable clot. Then you're going to get inflammation. So shortly after, your skin's going to swell up a bit. It's going to get bigger, it's going to get red, it's going to get warm, things like that. And then perhaps after a day or so, your cells are going to start being produced, and those cells are going to mature until you fix your injury up. So a cutaneous skin wound, just as a definition, is just a cut in the skin. So perhaps you were making dinner one night and you accidentally sliced your finger a bit. So it's fairly common, and it involves your skin repairing itself. And depending on the cut, you can either have something we call first intention or second intention. And the difference between first and second intention is whether or not the walls of the wound are in contact with each other. So for example, if you get a paper cut, yeah, A paper cut is fairly small, and it's just a small little slice in your finger. But the two exposed edges that you've cut apart still remain in contact with each other. So you're going to get first intention healing. So generally the healing is really, really good, about 70 to 80% of the overall strength. So you're less likely to rip it apart later on. So you can see that the first two steps are the same. Hemostasis and inflammation, they're always going to be the same. And after this, we're going to get fibrin. So we're going to get some connective tissue, kind of loosely joining the two edges together. And then we're going to get fibroblasts. So these are some of our specialized cells, and they make collagen, which is more connective tissue, just to join it up together. And then your epithelial cells. So just your skin surface will close up the surface. So it's fairly simple. You cut yourself, bleeding stops, it becomes a bit inflamed, and then we join the edges together. But if we have second intention, this is not as great, especially if we have a larger wound where stuff gets stuck in it, we're moving around a lot. The two skin edges can't really come in contact with each other. So this results in a bit of scarring as well. So as usual, your first two steps are hemostasis, and then this is followed by inflammation. However, the third and fourth step are a bit different to your first intention. So instead of just having our fibrin joining together the edges, we're going to have granulation tissue. And granulation tissue is kind of like, if you've ever gotten like a package, it's kind of like packing peanuts. And it kind of just makes up the space to try to join the edges together. So what happens is that your endothelial cells or your blood vessel cells will kind of start to form, and you're going to try to restore that blood flow there. And if you have blood flow, you're going to be able to bring cells in, such as your fibroblasts and perhaps your muscle cells as well. So it's going to form these cells, and then after these cells form in like a giant, huge bunch, these cells are actually going to shrink together. So by shrinking in together, it's going to bring the two edges in closer to each other, and it's going to reduce the amount of space we have to fill up. So this is kind of an attempt to return it to our normal state, but it's like a bit of a halfway point. And following this, we're going to restore the top of our skin. And I think the best way to understand this is through a diagram. So up the top, we have first intention. Down the bottom, we have secondary intention. So as you can see at the top here, we have a really tiny cut in the skin. What happens if we have a fibrin kind of joining it together, and the tissue slowly forms back up. And it's really, really nice. It's a really clean process, and it looks basically the same after we're done. However, if we have secondary intention, this is like a huge chunk of our finger has been cut out. So we're going to get this giant clot, and we're going to have this granulation tissue form. So it's a lot of tissue, and it forms really large, and then it shrinks down afterwards. And then after a while, after we form some scar tissue, some different cells as before, we're going to get this secondary intention healing. And this is going to be mostly scar tissue, a bit of the original tissue, but mostly scar tissue. So not as favorable, but still good. So we just covered cutaneous or skin damage. This next one is about GIT wounds, or in your stomach. So what happens is that you have layers in your stomach, right, to protect you from your acid. So what happens is that if you break through that mucosal layer, so if we break through that mucosal layer, we're going to, your stomach acid, which is like really acidic stuff, is going to burn through the stomach layers. So obviously that'll be painful. You're going to get inflammation. You're going to get a bit of bleeding. So therefore, you're going to get hemostasis to stop the bleeding, so you don't bleed to death. Your inflammation will occur because all your cells are migrating in, and you're going to get granulation tissue. Granulation tissue, it's the formation of the scar. It's like the initial, it's like you're packing peanuts, and then they kind of bring together the edges. So it's kind of just like a space filler to close everything up properly. Otherwise, you'll get like a giant bubble inside your skin, if that makes sense. And then after a while, for your stomach or your intestine or wherever, the epithelium, like the mucosal epithelium, will reform so that the acid doesn't burn through again. So we've covered cutaneous, we've covered GIT, and now onto bones. So since bones are highly vascularized or have a lot of blood in them, they're going to be able to form, they're going to be able to repair pretty well. So once again, you want hemostasis and inflammation to occur. Like hemostasis and inflammation will always occur, no matter where you are. And after this happens, our bone is going to be kind of joined together temporarily by a cartilage callus. So it's going to be like a mixture of our collagen and our connective tissue, as well as a few of our osteoblasts, which are like the precursors to our bone. And after a while, these cell types will change and we produce a normal functioning bone again. However, this process can be interrupted if you're like moving around a lot, if there's like shrapnel in between there, if some soft tissue gets in between there as well, if you don't have enough calcium, if you have bone disease, osteoporosis, that kind of thing. So if you want to repair your bone, you want to keep it still, which is why we put it in like a cast or like put pins in to keep it all together. But just in general, with our healing, we're going to have a few factors that affect it. So I think these are like fairly self-explanatory. But if you're infected, your body's not going to devote as many resources to it. If you're not eating well, your body can't use those resources. If there's no blood supply, you can't have the cells. If they're foreign bodies, the healing's going to be blocked. If the injury is in a certain location, it may heal better compared to other locations. So for example, if you cut your hand, it's going to repair fairly okay. But if you cut, say, if you say damage your kidneys, for example, your kidneys aren't going to heal together as well. If you move a lot, it's going to move things around. And glucocorticoids is like an important one to remember. Glucocorticoids kind of interrupt with everything because they mess with your gene transcription. They mess with your steroids. They're useful, but they have a lot of side effects. So those can affect our healing. And then lastly, does anyone have any questions before we move on? Otherwise, we'll go to...
There was a question in the chat. Someone asked, is granulation tissue the formation of a scar?
Yep, I've answered that one.
Oh, sorry.
Yeah, all good. Otherwise, we'll do adaptive immunity. So it's like round 2 of your immunology, but this stuff's actually important. So just as a recap, our adaptive immunity is our third line of defense, and it's going to provide really specific, really targeted, and really strong responses towards infection and pathogens. We have a few key cells. Our dendritic cells are kind of like the patrol cells of our body. They're going to go around the body looking for these pathogens, and they're going to phagocytose them or engulf them, and then digest them, and then stick out like a flag saying, hey, this pathogen is somewhere inside the body. We need to go get rid of it. And after that, we have T lymphocytes or T cells and B lymphocytes or B cells. T lymphocytes are mostly important for intracellular, it's more important for intracellular pathogens, whereas B lymphocytes are more important for extracellular, outside the cell pathogens. But we'll go into more detail about these T lymphocytes and these B lymphocytes. So this is a bit of a recap once again. So as I said before, your dendritic cells are going to be patrolling around the body. And once they come across a pathogen or an unknown substance, it's going to engulf it and it's going to digest it, and it's going to get like a flag from that pathogen, which is what we call an antigen. And it's going to hold this antigen, and it's going to go to our lymph nodes. So our lymph nodes are like this collection of our immune cells. It allows for this really fast processing of these pathogens. And what's going to happen is that this dendritic cell is going to take this antigen and it's going to give it T cells, particularly T helper cells. And these are going to help to initiate an immune response. So these T helper cells will eventually stimulate our B cells, and our B cells, or our B plasma cells, will produce antibodies. However, we have two different types of T helper cells. We have type 1 and type 2. So, so type 1, this stuff's fairly important. It comes up again in year 2. Type 1 is primarily for intracellular pathogens, so things like your viruses, whereas your Th2s are more useful for like your parasites as well as extracellular pathogens, so like your bacteria, things like that. And each of the Th1 and Th2 will release different cytokines. So the main ones to remember, I think, for Th1 is interferon gamma, whereas Th2 you have 4 and 5, as well as 13. That's also involved with Th2. Those cytokines are fairly important to remember. Yeah, just remember those ones. Okay, I repeated a slide. So we've talked about the immune response, but what happens if we want to stop the immune response? Well, we have some genes, sorry, not some genes, some receptors called CTLA4 and PD1. These are inhibitors of the immune response, so therefore it will stop the immune system from attacking it. So this is good because we don't want an overactive immune system. However, it's also bad because some tumor cells or some cancers, some polyps, things like that, will be able to express these, will be able to express ligands or things that activate these receptors. And if these tumor cells are able to express that, that will mean that your tumors will be able to evade our immune system and proliferate without getting any attention. So this is bad because our immune system is then no longer able to cut off these cancerous cells. They're kind of let to run astray. Okay, so now we'll be talking about our viral infections. So we're talking about our viral infections. So viral infections are important to note because they are intracellular pathogens, because they rely on our host machinery to replicate and distribute themselves. So since they're intracellular, when our dendritic cell comes across this infected cell, it's going to notice, hey, this cell doesn't look normal. It has these weird antigens being presented on this cell surface. So what it's going to do is this dendritic cell will come along and it'll phagocytose our infected cell. And as a result, all of our viruses, all of our viral proteins and things like that are going to get digested within this dendritic cell. And it's going to get this antigen or this like flag for this virus. And it's going to present it on its MHC class 1. And from there, the dendritic cell is going to go to the lymph node. At the lymph node, it's going to activate our B cells. And our B cells are going to make these antibodies, these really, really specific antibodies. And these antibodies will be produced in like millions. And it will go out throughout all the blood, and it will latch onto the virus and stop them from working. So therefore, we've stopped this infection. This process is the same for tumors as well. So it's going to phagocytose our tumor cell, it's going to digest it, it's going to find the antigen, it'll go to the lymph node, it'll present it to B cells, B cells will produce our antibodies, and our antibodies will go out and kill our tumor cells. We also, in addition to our antibodies, we also have cytotoxic T cells. that'll also find the same antigen that was originally presented to them, and it'll kill them. And this is primarily through perforins and granzymes. And these substances, perforins and granzymes, will initiate apoptosis. So it'll kill the tumor cell. But back to antibodies. These antibodies can have various effects listed here. So one, it can either attach and say, hey, come over here and phagocytose this cell. This cell is bad, come and destroy it. Or our antibodies can also directly kill our cell, as well as activate other cells, such as mast cells. So these antibodies can attach to our mast cells, and these mast cells might release histamines, which might help with the response. As well as antibodies are also able to activate our complement proteins. So our complement proteins are a set of soluble proteins that kind of circulate throughout the blood. And at certain times, these complement proteins will be activated in order to activate these complement proteins. What antibodies do what? So you have 5 types of antibodies. All of the antibodies can affect, all of the antibodies can basically do probably most of these things. The main one for mast cells, at least, is IgE. But yeah, typically your IgG is for long-term antibodies. So this is the type of antibody that you get if you've been immunized a long time ago. You'll find traces of your IgG antibodies. Your IgM ones are kind of immediate. They're our acute, quickly onsetting antibodies. IgA is for mucosal surfaces, so like our nose, our mouth, our lungs, and also from the other end. IgA, IgE, IgM. And then what's the last one? I forgot what the last one is, but it's not that important. IgH, IgD, G. I've done G. Anyway, the last one's not that important. IgD.
Yeah, IgD. You don't have to know it because the lecturer was like, even they don't really know what it does yet. So
yeah,
yeah,
there you go.
Don't worry about it.
The main ones are G, M, E, and A. But yeah. So all of them are kind of able to do these 4 actions on the slide. But yeah, different antibodies are more inclined to do certain actions and more inclined to be found in certain locations compared to others. You also see, this is just a definition that's useful for any tests or any exams, things like that. Opsonization is coating. So often, since we have so many antibodies, our antibodies will like stick all around a cell, like it's like it'll just surround it and it'll just coat it all in antibodies. So it's like literally impossible to miss. Yeah. So as I said before, our antibodies and our immune system can be turned off. And if it doesn't get turned off, we kind of get an overactive immune system. And this can result in either allergies or our autoimmunity. So allergies are to normally safe substances. So peanut allergy, a peanut shouldn't hurt you, but our immune system thinks it can. And therefore it's like, let's respond in like the most violent way and kill the person in the process. So that's our peanut allergy. Whereas autoimmunity is where your body realizes, hey, you see this organ here? This organ looks weird. Let's kill it, even though it's meant to be there. So both allergies and autoimmunity are due to overactive immune systems. And then lastly, contact sensitivities. These aren't as bad as allergies. They're kind of just like when you get a small little rash from something. And that's just in response to a chemical or environment. So often like plants, henna, which is like tattooing of some sort, I think. these are more normal responses, and these can help us. Whereas allergies and autoimmunity are just like straight up useless. No one wants them. Yeah, and that's the end. Does anyone have any questions about our immunity or our cell healing or our repair? Otherwise, I'll just plug this Saturday. So Saturday we'll have like our study thing. So we know you guys have your Anki session on Friday, I think, like Friday evening. So that's just Anki. I would still go to that. That's fairly useful, I think. But Saturday we'll be going through Anki. Like if you have any questions about setting it up, we'll go through those, as well as we'll go through like different study methods, organization, exam prep, what was really high yields from last year. So you'll get to see our exam breakdowns from last year, which faculty doesn't really provide. So you'll only be able to see that on our slides. And we've like packed it so full of memes. Like we just went to town. It's so good, I think, I hope. So yeah, come on Saturday. I don't know how long it'll go for. Like it shouldn't go for too long, I think. But yeah, good time to ask questions and things like that. Yeah, and we'll be going through like real examples of like what my study setup looks like, what my Anki decks look like. So you'll be able to see how those work. Otherwise, I think that's everything we want to go through. So thanks everyone for coming. Good luck with the rest of your OCEs. Good luck with the rest of the week. And hopefully we'll see you Saturday. Yeah, recording will go up soon.
Thanks, guys.
See you.
Thanks for coming.
Bye-bye.